So I told you a little while ago that when you evaluate these static and dynamic measures, that one of the key elements is, of course, the limitations of the studies that we've had at the moment in terms of size. And that the categorization of 10% was really to eliminate any argument on anybody's part about the level of importance. Ron Dubois was able to access the GIPF-01 and the GIPF-07 databases, which gave him upwards of 1,100 patients to look at. You see, there's a power limitation when you try to look at this kind of data until you get very large numbers. And when he was able to look at all 1,100 patients together and see how they behaved, because data was collected every quarter like clockwork, he was able to discern all the same findings, but at much lower levels of change to indicate the same risk profiles. That is to say that while age did not hit statistical significance, there was a clear correlation, or trend, if you will, of age being important in terms of survivorship. The level of FVC, again, had a trend in the expected direction. The worse you were, the more likely you were to suffer mortality. Hospitalizations, no surprise. The more often you were hospitalized, or if you were hospitalized, the more likely mortality was to ensue in the following year. But dynamic changes in FVC, you can see, were very strongly correlated. Again, greater than 10% decline had a p-value of 0.001. But a 5% decline had a p-value of 0.009. What does that tell you? It tells you that if you've got enough power, you can see that the real difference is between that stable line that I drew you to begin with and any measure of decline. That some measure of decline is probably not good. Again, stating the obvious. Decline in DLCO, same thing. And this is an interesting one that's been borne out in a few studies at this point. If you're more short of breath this year than you were last year, the sensation of being more short of breath, that's probably a predictor of poor prognosis as well. Both on the San Diego score and on the St. George Respiratory Questionnaire. What about biomarkers? Well, the nice thing is that this is a growing area that I will tell you 3-4 years ago there was very, very little, and we're seeing more and more. There are some nice publications looking at matrix metalloproteinases, in particular MMP7, that show a nice receiver-operator curve correlation. Surfactant proteins A and D have been looked at. TGF-beta1 has been implicated as having a high, very important role in the pathogenesis of this disease. KL6 has been looked at. And then collagen turnover products have been looked at as well. And there are other emerging markers. I really only picked one to kind of demonstrate how this works. You can measure this stuff in the serum or in the BALs and take a look. And you can see that these are not a small number, 152 patients versus 219 total in ILD. And if you had low-level KL6 that was better than a high level of KL6 in terms of the survivorship over the ensuing 80 months. And so we're moving in that direction, and we need to get there because all of those physiologic markers that I showed you are essentially surrogates for mortality. And at the end of the day, as I get to the trial designs that you'll see here at the end of the talk, we're always looking to affect mortality. That's what, that's the big kahuna. That's what we're trying to get, right? And the problem is, can you conduct a trial with a surrogate that's going to give you that marker? And that's where we keep, cracking our skulls to get a better design, a more efficient design, to make an estimate of that so that we can figure out whether a drug works or not. And as you get more of these kinds of biomarkers, it makes it easier to do. Now, this is an interesting study of not really a biomarker, but it's still a predictor. And the reason I put it up here, because I think it really helps to explain how pulmonary hypertension is starting to come into the equation. This was a study by Song this past year. I actually saw it presented the year before, in which they took a look at two aspects. The first was taking a look at the beta natriuretic peptide, which is basically a measure of atrial stretch. And we're able to show that patients with high atrial stretch didn't do as well versus those with normal. Now, the biggest reason for atrial stretch are congestive heart failure patients, but another reason are right heart failure patients or pulmonary hypertension patients. They then took a look at the measures of pulmonary arterial pressures, I believe it was by echo, and stratified them into basically not significant, moderate, and severe. And no surprise, the worse the sign of pulmonary hypertension was, the worse the survivorship compared to those with mild disease. They then superimposed the two. In other words, did you have a high BNP with a high measure of pulmonary pressure, and clearly demonstrated, again, a much worse survivorship. So you can start to combine elements to get a much more sensitive predictor of how the patient course is going to be. And you can see the survivorship here out to 25 months in patients with no signs of pulmonary hypertension and no elevated BNP was excellent. This show you how a lot of this stuff gets to be generic. This is a study by Dave Zisman, who took a look at albumin. Albumin is a protein that you produce normally as a measure of your nutritional status. And the argument here isn't whether or not albumin is important in IPF, but as the patient gets sicker and sicker, is it being reflected in the albumin levels? And indeed, those with poor albumin levels had much poorer survivorship. And this was published again this past year, compared to those with normal albumin levels. And it may reflect malnutrition or other processes. And really what he was doing was applying a good idea that had been looked at in other disease states that have been used in lung transplant populations to demonstrate this kind of correlation. Now, I really picked this out to make the point that how the patient is doing overall counts. It's not just how the lungs are doing. So do those comorbidities matter? Do they affect mortality? Well, hopefully I've set the stage there just with the prognostic material. Can study design influence or create awareness of them? Absolutely. So let's talk about pulmonary hypertension for a second. Depending on which study you look at, and really which population those studies are looking at, the rate is somewhere between 32 to 85%. The point is it's prevalent. It's around. It's there. In the UNOS database, it's about 45% of the patients, and about 9 to 10% have really significant pulmonary hypertension. And you can pick it up early with exercise as well. How much does it vary? It really, as I said, kind of depends. And you can see that the prevalence of pulmonary hypertension, depending on which study you look at, goes from 28 to 84%, but most of it's sitting at somewhere in the 40 to 45 mark. And that's probably somewhere hitting truth. So is it significant? There's no question. I've clearly demonstrated to you that it shows and portends a poor prognosis. But you got to have a right heart cath to be definitive about it. I'm going to show you why here in just a second. And so can you use surrogate markers to avoid sticking a catheter into someone and measuring pulmonary pressures directly in the heart? So this study by Steve Nathan took a look at the value of echocardiography. Now the problem with echo is it's qualitative, not quantitative. And what he basically shows here is that when he correlated it with the actual right ventricular systolic pressure and measured it along the FVC lines as a predictor for pulmonary hypertension, it doesn't really line up very well. And it's off. But it can be predictive of where you're going to fall. So it's not very accurate, is its problem. And ultimately, at least for now, we have to use a right heart cath as a gold standard. Although I think that Song paper points us in the right direction of how to use more than one piece of data to be more accurate in our assessments.